Hello, everyone. I'm Yen Bui. I am chair of ISTM's Professional Education Committee, and I want to welcome all of you to our very special webinar on yellow fever. Special thanks to Tara Lombardo and the nursing professional group for putting together this wonderful session. And thank you to Carl Hess, immediate past chair of the pharmacist professional group of ISTM, for agreeing to be our moderator today. Over to you, Carl.
Thank you for that, Yen. So welcome everyone to today's webinar on yellow fever. I'm your moderator for this ISTM educational event. I just have a few announcements before we get started. Please note that today's program is being recorded and all attendee audio and videos is muted. Today's presentation will last up to 90 minutes and includes question and answer opportunities. So please submit your questions at any time throughout the presentation through the Q&A panel link at the bottom of the screen. Please note that the chat is not monitored for questions. To ensure your question is received, please use the Q&A panel to submit those questions. During the Q&A at the end of the webinar, our presenters will answer as many questions as time allows. And I believe for those that we don't get to, we'll be sending out a follow-up handout for that. You may turn on closed caption services during the webinar. There is a live caption button on the bottom of your Zoom screen. Please note that this is a free service provided by Zoom and may not be 100% accurate. The slides for this program can be accessed on the Handouts tab of this program, located at learning.istm.org. You will find the webinar page on your Learning at ISTM dashboard once you are logged in. Now that we have gone over the announcements, ISTM is pleased to present this online educational webinar, Get the Practical on Yellow Fever, panel discussion and case studies. This webinar is produced jointly by the Professional Education Committee and the Nursing Professional Group of ISTM. Special thanks to our sponsor, Sanofi, that helped provide and support this program. So just to introduce our planning committee and our speakers. So we have Dr. Yen Bui, who's our chair, Tara Lombardo, who is the co-chair of the Nursing Professional Group, Dr. Darvin Scott-Smith, who's also co-chair of the Professional Education Committee with Dr. Bui, and Dr. Lin Chen, past president of ISTM. Our speakers for today are Catherine Keel, who's a nurse practitioner at Travel Health Practitioner Pty Limited, Jane Chiodani, Candice McAllister, who's the Infectious Disease Control Program Officer at ExxonMobil, and Linda Boss, a nurse coordinator at Michigan University. Thank you, everyone. Enjoy the webinar.
Hello, and thank you for the introduction, and thank you for allowing me to discuss yellow fever today. I'd just like to take this opportunity to thank the Australasian College of Tropical Medicine for providing some of these slides, which we have used in the yellow fever workshop during the Southern Cross Travel Medicine Conference. So this is my declaration of conflict of interest. In the past, I have worked with Sanofi in regards to travel vaccines and GSL Seqirus in regards to Q fever. So I'm going to briefly discuss the history, clinical illness and transmission of yellow fever today, but spend most of the time on the epidemiology of the disease, vaccine recommendations, scope of practice for practitioners and resources. Obviously, a lot of information in 20 minutes, but I will do my very best. Please note I will discuss resources at the end of my presentation, but I do implore you to do further reading. Okay, so this is a very busy slide, but an interesting and important one showing the history of yellow fever disease. And the term yellow fever was first used in the Barbados outbreak of 1750, and we started to see the yellow quarantine flags on the ships. Just give you a minute to have a look at this slide. So as we are aware, yellow fever virus is a single-stranded RNA virus that belongs to the genus Flavivirus. Other members include dengue, Japanese encephalitis, West Nile, tick-borne encephalitis, and Zika. We're just going to touch on clinical illness. I'm not going to go into too much detail just because of time. But as we'll be aware that most people are infected with yellow fever have minimal or no symptoms. For those who develop symptomatic illness, the incubation period is typically 3 to 6 days. And the initial illness is normally non-specific. So things like backache, fever, headache, nausea, and vomiting. And most improve after this first initial presentation. After a brief remission of less than 48 hours, 15 to 25% of affected patients progress to a more serious form of the disease, and case fatality is 10% to 50% in the indigenous populations in an endemic area, but can be higher in unimmunized travelers. So all travel-related cases in the last 2 decades have had about 30% fatality rate. So as already discussed from the previous slide, these are the potential different stages of clinical presentation of the yellow fever virus. And again, a useful graph explaining about the 3 potential different stages. Now, yellow fever is a notifiable disease. A preliminary diagnosis is based on clinical presentation and exposure details. Lab diagnosis is best performed by virus isolation or nucleic acid amplification tests or PCR tests, or by serology. Obviously, PCR has to be taken with the first 10 days of symptom onset. And treatment is really supportive. There's no specific medications available to treat yellow fever virus infections. We really need to treat symptomatically and any life-saving interventions. Now, the virus is transmitted by certain mosquitoes that acquire it when they feed on infected monkeys or humans. Probable transmission of yellow fever vaccine is from a mother to her infant has been recorded, and also via breastfeeding. Theoretically, there can be bloodborne transmissions occur via transfusions or needle stick injuries. Now, I'm just going to touch on the transmission cycles briefly due to time. As we're aware, there is the jungle, the savanna, and the urban cycle. Now, the jungle cycle is most common in South America. The virus is transmitted by mosquitoes from monkeys to humans when the humans encroach into the jungle during occupational or recreational activities, and humans become incidental hosts when entering the forest. Now, this is a photo of the brown howler monkey you might be aware of, which is the most susceptible non-human primate species to get the infection from yellow fever. Now, the savanna cycle, which is more common in Africa, and the transmission of virus between non-human primates and human to human via these mosquito vectors. And lastly, the urban cycle involves transmission of the virus between humans and peri-domestic mosquitoes. And we frequently see outbreaks in Africa in regards to this cycle. And again, a useful diagram showing the different transmission cycles, how they relate to one another. Now let's move on to the epidemiology of yellow fever virus. And as we can see, we have 29 countries in Africa and 13 in Central and South America where we find yellow fever virus. And again, these maps are all taken from the World Health Organization, CDC. And there's a list of the African countries. Just be aware that there is some countries that are not on this list, which has low potential for exposure to yellow fever virus. And these include countries like Eritrea, Rwanda, Somalia, Tanzania, and Zambia. So we're aware that yellow fever is endemic in monkeys and patchily distributed in 29 countries in sub-Saharan Africa between latitudes of 15 degrees north and 10 degrees south. It causes an estimated 200,000 human cases of yellow fever with 30,000 deaths annually. But although there are far fewer cases, there's probably a lot more cases that haven't officially been reported to the World Health Organization. Now, moving on to South America. These are the list of countries, 13 South and Central American countries which are affected by yellow fever. Now, yellow fever is endemic in monkeys in eastern Panama, Trinidad, and 11 tropical countries to the east of the Andes, up to an altitude of 2,300 meters. Peru, Brazil, Bolivia, and Colombia, especially around the Amazon basin, presents the greatest risk for human infection. Illness most often is in young men who enter the forest areas for their work. So just as a summary, again, in South America, incidence is highest during the rainy season between January and May, with peak incidence in February and March. In West Africa, transmission is seasonally peaking during the end of the rainy season and beginning of the dry season, usually July to October. Just be aware that if there's no reported yellow fever cases or outbreaks, it does not mean that we need to reduce our protective measures. We still need to think about potential of yellow fever infection. Okay, a useful map, and especially for me based in Australia, it shows the distribution of the principal vector for yellow fever. And as you can see, we are aware of Central South America, we're aware of Sub-Saharan African, and then obviously the vector there is in Asia and parts of Australia. So why has yellow fever not arrived in Asia? To be honest, we don't really know. We have the vector here. There are some possibilities as discussed here. I'm more than happy to, have a discussion on this after all our presentations, if anybody has any insightfulness. So, what is the risk to our travellers from yellow fever virus? Now, we obviously need to be aware of the following information. We need to be aware of their travel destination, the intensity of yellow fever transmission in the area they're visiting. What's the current outbreaks? What's happening in that country, that area within the country? Season of travel, duration of travel, activities allowing exposure to mosquitoes. Are they camping? What are they doing? Are they near doing water activities? What are they planning to do during their travels? And that obviously that immunization status is really important. So taking a full history is obviously, we're aware, is extremely important in our pre-travel health consultation. Now, most of you will be aware of these facts, and I do actually share this openly with my travellers. Risk is obviously a lot less in South America, because mosquitoes in the forest canopy involved in transmission cycles in monkeys only rarely come into contact with humans. Also, there's a higher level of vaccination coverage and hence immunity in local communities, and this reduces the risk of transmission. Risk is 10 times higher in West Africa, and obviously much higher during outbreak scenarios. Okay, so the yellow fever vaccination, it's as we're aware, it's a live attenuated virus vaccine. It's made by sequential passage of the virus through various substrates until its virulence is decreased, and it's obviously grown in chicken eggs. And a single injection of the yellow fever vaccination induces a broad spectrum immune response. Saying that after 28 days, it gives a 99% immune response. We're aware that we give yellow fever vaccine for two reasons, obviously. Initially, is to prevent the international spread of yellow fever by protecting countries from the risk of importing or spreading the virus. And this is our clear requirement of health regulations. And we also need to give the vaccination to protect individual travellers who may be exposed to the yellow fever virus. Now, international health regulations permit countries to require proof of yellow fever vaccinations documented on an international certificate of vaccination. And this is a condition of entry for travellers arriving from certain countries to prevent yellow fever virus importation and transmission in their destination country. Now, this slide, obviously from the ISTM, shows the contraindications and precautions of the yellow fever vaccine, which we're going to discuss in detail in a moment. Really important slide, okay? We need to be really aware of these, do extra reading on these, before we even think about advising about the yellow fever vaccine. Now, as we should be all aware, in travel medicine, there are three syndromes or adverse conditions in relation to yellow fever. The first one is a severe allergic reaction or anaphylaxis, which is extremely uncommon. This happens about 1 in every 50,000 to 125,000 people who receive the vaccine. CDC state 1.3 cases per 100,000 doses administered. Then we got yellow fever and vaccine-associated neurological disease, 0.8 cases per 100,000 of vaccine administered, but you can see how it increases to 2.2 per of 100,000 doses in people aged 60 years or over. And then we've got the viscotropic disease, which is symptoms are very similar to yellow fever disease. And we see that this can occur in 0.3 cases per 100,000 doses of vaccine administered and increases to 1.2 per 100,000 doses for our older travellers or 60 years or over. So we really should be aware of all this. I often show these figures to my travellers for us to get informed consent, which is really important. So let's have a look a little bit about the grey areas, okay, of yellow fever. Okay, so duration of protection. Now, immunity considered lifelong as from the 11th of July 2016. So the World Health Organization Strategic Advisory Group of Experts in Immunization concluded in April 2013 that a single primary dose of yellow fever vaccine is sufficient to confer sustained immunity and lifelong protection against yellow fever disease. And a booster dose of the vaccine is not needed. So in May 2014, the adoption by the World Health Assembly happened and the Annex 7 was updated, extending the validity of the certificate of vaccination against yellow fever from 10 years to life. And this came into force on the 11th of July 2016. Now, these recommendations are Australia-based. They're from the Australian Immunisation Handbook, and I would implore you all to consult with your own state, territory, and country regulations for your own recommendations for booster doses. So another great area is the older traveller. Okay, so as highlighted in the previous slides, age of 60 years or older is a precaution, not a contraindication, but a precaution for the yellow fever vaccine. We need to consider the risks and benefits of vaccinating older travellers against yellow fever virus, and we need to consider the benefits of vaccinating them for the first time. We need to have a discussion with them. We need to get informed consent. So again, looking at their travels, where they're going to, their risk, their medical history, and so forth, and what they're planning in the future. So it's a joint decision between you and your traveller. Okay, so pregnancy. So pregnancy is a precaution for vaccination. Safety of the vaccine in pregnancy has not been studied in large trials. However, there has been some smaller studies. Excuse me, a Brazilian study of women who were vaccinated with yellow fever vaccine early in their pregnancy found no major abnormalities. Another study showed a slight increased risk of congenital infection between 1 to 2% following yellow fever vaccination. So if possible, pregnant people should avoid travel to yellow fever risk areas. Okay. Now, pregnant women who have high risk can be given the vaccine. So if they're going to an area where they have to travel to, there's an outbreak situation and travel is unavoidable, then the risk outweigh, it's felt that the vaccination risk is less than the risk from the virus. By contrast, if the vaccine risk is believed to outweigh the risk of the yellow fever virus exposure, we often suggest a medical waiver to the traveller to fulfil health regulations. Remember, we need to have informed consent, and it's a discussion between the clinician and traveller. Excuse me, the Advisory Committee on Immunisation Practices recommends that women wait 4 weeks after receiving the yellow fever vaccine before conceiving. And just be aware, pregnancy can reduce the immune responsiveness of the vaccination. In regards to breastfeeding, again, a precaution to the vaccine, limited data, but there are cases of transmission of the yellow fever virus. Try to avoid the vaccination in breastfeeding women. Though there's no data available to support this practice, as highlighted in the CDC Yellow Book, some experts recommend that breastfeeding people should pump and discard their breast milk for more than 2 weeks after the yellow fever vaccine before resuming breastfeeding. Now, I'd be interested in anybody in the audience who has more information on that. Again, in children, the yellow fever vaccination is contraindicated under 6 months, precaution 6 to 8 months. Moving on to another grey area is the immunocompromised. Now, yellow fever vaccine is contraindicated in people who are immune suppressed, whether due to an underlying primary disorder or medical treatment. The above information on the slide is taken from the Australasian College of Tropical Medicine slides, and I would really highlight it's a suggestion, okay, of the cut-off points of immune suppressants. I'd strongly advise any practitioner to follow their country guidelines and discuss with a traveller's specialist if they're immune compromised before they administer the yellow fever vaccine. Safety first. It's really difficult to ascertain at what level a patient is immune compromised. Now, just moving on, and I know we're running out of time, just a few extra grey areas. Obviously, it makes life harder for us as practitioners if there's differing national and international policies on who needs yellow fever. And there's inconsistency between World Health Organizations and country-specific entry requirements. Example of this is Mozambique. I think I saw that on the listserv recently with their recommendations. Intermediate transmission risk, reasons are neither high nor low. Our travel clinics, we might be overcautious, are we? So this can lead to over-vaccination and unnecessary exclusion from those contraindicated. Outbreak situations, during an outbreak, vaccination campaigns might target broader populations, which may conflict with routine recommendations that we go by, so it makes life a little bit tricky for us. And obviously in travel medicine, we're educating the traveller on lots of different things, and including mosquito-borne diseases. So it just adds to the confusion sometimes explaining about yellow fever when you have to talk about malaria and dengue. So just be nice and clear, give handouts where appropriate. Okay, so just swiftly moving on, extremely useful decision-making tool you might have all seen. This is for precautions. So following the flow chart is important. And again, this is all going to be, you'll be able to see my slides after my presentation. Okay, again, contraindications, and we might think medical exemption letters or waivers may be indicated if vaccinations are contraindicated for medical reasons. But maybe indicated where there's a medical contraindication and they're not actually entering the endemic zone, but may require a certificate to fulfill the international health regulations. But we must be aware that if they are going to an endemic zone of yellow fever and there's a reason for them not to have the yellow fever vaccine, we should advise primarily against travel. And just due to the risk of them catching the yellow fever virus. And we must be aware that if they have had a waiver, it doesn't preclude them to quarantining the traveller on their way back into our country. So just be aware of that. Okay, scope of practice. Now, this is some information here. So we're aware that scope of practice outlines the expectations for all practitioners when determining if they have the authority to perform a specific activity, i.e. administer a yellow fever vaccine, if it's appropriate for them to perform in their current setting, are they accredited yellow fever vaccination centre, if they are competent to perform the activity safely. This is some guidelines. Every country is different, and I've just used the example of Australia. We follow the national guidelines for yellow fever vaccination centres and provider, which the link is there. And a practitioner seeking to prescribe the yellow fever in Australia and in a yellow fever vaccination centre is required to successfully complete the online yellow fever vaccination course and obtain a completion certificate. And this needs to be done every 3 years in Australia. Nurse practitioners are also eligible to seek accreditation to prescribe the vaccine, providing that yellow fever vaccination is within their scope of practice and is included on their prescribing formulary. Ultimately, state and territory health authorities must approve who is eligible to prescribe the vaccine. This is in Australia. A nurse may administer the vaccination and sign the certificate under the delegation of the prescribing practitioner. So all I would say in regards to scope of practice, please do your homework within your state, territory, country, what you're allowed to do, what you're not allowed to do. There are obviously some links there that can really help. It's really important. And just lastly, moving on to resources. Okay, this is a very brief summary of yellow fever. So I do really encourage you to all to do further readings if you feel that will be beneficial to yourselves. Example, this is from the UK, some resources that are excellent, especially highlighting NAFNAC, who have an excellent consent form for your traveller to sign, and form consent. And obviously the Green Book, which is very important in the UK. Every country has their own set of resources, and I would like to highlight, this is just from NAFNAC, highlight the Nursing Professional Group Hub, which is a new digital resource that has been very kindly prepared and created by the Steering Council of the ISTM and Jane, and it's a brilliant resource. So it has many resources, international resources. So I really implore you to have a look. The link will be on the MPG page on the ISTM website. And I have also included the link in my reference list. So this is a thing, just go on. It's not just about yellow fever, it's about all travel medicine. Lots of really useful resources for you to read and refer to. Okay, this is just a summary. I will be quiet in a moment of what we've spoken about today. We just gave a brief summary on clinical disease transmission, the cycles and epidemiology. We really got to focus on those grey areas in vaccine recommendation. We obviously have differing regional risk, inconsistent global vaccination policies, and contraindications for certain populations, which makes our job very complex at times. We need to do tailored risk assessments, and we need to have really clear communication between practitioners, health authorities, and travellers, and that to manage those really grey areas effectively. And that's just my list of references. The rest of the references are on the MPG Hub. And I want to take the opportunity to say thank you for listening to me. And I hope you're enjoying our presentations. Thank you.
Hello, I'm Jane Chiodini, a travel health specialist nurse working in the United Kingdom. I'd like to thank the organisers very much for all the hard work that's gone into preparing this session. Unfortunately, prior commitments mean I cannot be with you today, but I hope you find my talk interesting. And I've also prepared a platform of resources to support the presentation going forward, which I'll tell you about more in a minute. I have no conflicts of interest. I think risk communication is a challenging subject, but one that's so important to ensure our travellers are advised correctly. But this picture speaks volumes because no matter how high your level of knowledge on the complex topic of yellow fever, people need to know you care, and that really involves understanding your traveller and how best to communicate the risk to them. So the outline of this talk focuses on what risk communication is, some of the methods you could use to discuss risk with your patients, and I'm providing many resources to help, which I'll show you in a minute. Risk communication is a large and complex subject, really hard to cover in this short talk. So I have made a microlearning site which has links to many of the things I'm going to present, along with a longer presentation of this talk. I'll show you this slide at the end again, but you will also be able to find links to the resources in follow-up materials sent out from the ISTM. First of all, what is risk? Well, it's defined as the probability that a hazard will give rise to harm. Within travel medicine, although we now have a growing body of evidence, there's still a long way to go, and in many areas it would be difficult to communicate the probability of a risk occurring. Moreover, travellers can be challenging because they often are not sure about their plans for travel, and even those who are can change their itinerary or activities whilst away, to the extent it would often be difficult to communicate all risks. This is a very good paper. Something that I used back in 2013 was when I was talking at an ISTM conference on risk communication, and it remains a great source of information today. So risk communication is an open two-way exchange of information and opinions about harms and benefits, with the aim of improving the understanding of risk and or promoting better decisions about clinical management. And why is it important? Well, there is good evidence we would hope to change a traveller's belief and promote a change to their behaviour. For example, thinking twice about hiring a bike or moped abroad, and if they do, to ensure they always wear a crash helmet. To get a two-way discussion running, resulting in the traveller making an informed decision. For example, if going to a malarious area and there are an option of chemoprophylactic agents they could take. And finally, much of these decisions do depend on the traveller's own values, which we must respect. Because what is perceived as risk to one person isn't to another, and this is one of the hardest aspects regarding our discussion in a consultation. For example, I wouldn't dream of bungee jumping, but many would think it's fine. I find studying the characteristics of different generational groups interesting. Which one are you? I'm a baby boomer. I have 2 sons who are Generation Y and 6 nephews who range from Generation X to Z. All have travelled, but it's been interesting to observe their variation in risk-taking perception. Understanding the various views and values can help us perhaps in our approach within a travel consultation. This requires flexibility, but provides food for thought. I created this table pulling out just some of the differing characteristics. For example, attitude to technology if you wanted to get your travellers to continue to research a topic and learn more about the consultation. Or communication preferences, with older travellers being more comfortable in a face-to-face encounter, but a younger person very happy using technology. Risk communication used to be viewed primarily as the dissemination of information to the public about health risks and events, such as outbreaks of disease and instructions on how to change behaviour to mitigate those risks. Thinking on this has now evolved dramatically as social science evidence and new communication media technologies and practices have evolved in the 21st century. The way we present the information is important, but have we really analysed how well we have personally performed this action? Risk communication research has focused more on what we are doing rather than how well we are doing it. As the second bullet point states, as clinicians, we are communicating risk in our day-to-day work, but we will only change behaviour if our communication is effective. Clinicians need to be competent at understanding and explaining numbers, but such knowledge has historically not been taught in general training. Collective statistical illiteracy was a term used to describe how doctors, patients, journalists, politicians and society at large have trouble understanding and interpreting health statistics. Basic numeracy is also a problem. For example, in this study, only 21% of a sample of highly educated American adults could correctly identify 1 in 1,000 as being equivalent to 0.1%. This was a paper by Karen Leder et al. In the Journal of Travel Medicine about the complexities, limitations, and difficulties in understanding numerical risk data. It went on to discuss that we need to understand the risk concepts, but also the communication to travellers is also dependent upon risk communication and the risk perception of the health provider and traveller. The term collective statistical illiteracy was coined by this psychologist, Gerd Gigerenzer, and this is a really helpful video to watch in which he explains. I've put this in the microlearning platform I mentioned earlier so that you could watch it if you like, and I would strongly recommend doing so. Making statistics relevant and easy to understand by our travellers is important. For example, some say the risk of having an anaphylactic reaction to a vaccine is about 1 in a million. But what does that look like? How is the traveller supposed to understand it? Well, Wembley Stadium is the national stadium of England and the home of English football. It seats 90,000 people. So if you were to line up just over 11 stadia and give every person a vaccine, you would expect 1 person to have an anaphylactic reaction. That certainly helps to put it into perspective. I like this image where it explains if a vaccine is said to have an efficacy of 80%, it means that in a vaccinated population, if everyone was to be vaccinated, you would expect 80% to be protected against the disease. It doesn't mean that the vaccine will only work 80% of the time, or I've heard some think it means an individual would only get 80% protection, thereby imagining 20% of the body would not be protected, which of course is not feasible. There are problems around the language we use in relation to risk. For example, what does probable, unlikely, rare mean? This is a picture of our Deputy Chief Medical Officer during COVID in the UK, and he became a bit of a celebrity because of the analogies he used to use to explain risk. He's a keen football fan, so he talked about risk in terms of playing football or taking a train journey, and here is one he used for the risk of travelling abroad. When you go abroad, jumping into a pond with one shark in it or jumping into a pond with 100 sharks in it changes the likelihood that you're going to get bitten. From the literature, these are some of the methods which can be used to communicate risk. Now, time doesn't allow exploration of these, but I have included some in the longer version of the talk, which you'll be able to see in the microlearning site. We also talk about shared decision making. This is a two-way process that brings the choice together. In a travel consultation where, for example, there is a rabies risk, I would always discuss the risk and options, because we must always address the topic due to the potential fatal outcome an infection from rabies can have. And that shared decision making with your traveller will help them to understand the importance of taking all the necessary precautionary measures. Clinical equipoise is exceedingly challenging, and it happens a lot in travel medicine. For example, the giving of a yellow fever vaccine, where there may be a number of factors that complicate a decision to give a vaccine when it comes to reviewing the traveller's pre-travel risk assessment. In addition, clinical opinion may differ from one medical expert to another, or even from one country's guidance to another as well. In this situation, discussion and good risk communication style is especially important to make an informed, shared decision going forward. And we're seeing this in the use of the new dengue vaccine, Qdenga, at the current time, where a number of countries in Europe differ in their opinion as to its use. Interesting in that this latest position paper from the World Health Organization state that effective communication, including risk communication, will be required and that toolkits of communication should be developed. This would probably refer to the endemic countries, but I would also suggest we certainly need these measures when discussing the risk in our travel consultations. This is a list of actions in a general approach to risk communication. In terms of the last point on the slide, overload, I have always practiced that and taught practitioners to focus on 2 or 3 items of greatest risk to the traveller you're seeing and talk about these. It would be impossible to discuss everything in the time that we have. Neither would the traveller take it all in. And I always give written backup information, be it in hard copy or digitally. The evidence about the effectiveness of communication in healthcare from these 2 studies is of concern, in that up to 80% of healthcare information is thought to be forgotten immediately, and 50% of information recalled is incorrect. And one study in the UK showed that up to 61% of the English working age population does not routinely understand health and well-being information they receive. Health literacy is a term which was first mentioned in 1974. This document on the right was published by the World Health Organization in 2013, and this is a term that has evolved over time, but I wonder just how much we have considered it in a travel health consultation, particularly with more vulnerable groups such as visiting friends and relative travellers, especially when we also have a language barrier. Within the ISTM, the Digital Communications Committee, led by Dr. Sarah McGuinness, were tasked with putting some comprehensive traveller leaflets together. The challenge was to include information on the key facts, symptoms, prevention, treatment, and further information on just one page. Sarah told us of a tool which I've included in the microlearning platform, which will assess the readability score of the work and make suggestions to put the text into easy-to-read language for the intended audience. I have to say it was really impressive. Looking at this tool led me to more resources while I was researching for this presentation. One of them was Teachback, which I hadn't heard of before. We are so used to delivering our consultations in a style we develop to accommodate outside factors such as volume of topics and information to impart, the pressure of time we may have, etc. But do we actually know how effective we are? And do we really check understanding? What if the traveller feels embarrassed that they don't fully understand what we've said? Would we really know? Well, Teachback is a method that may overcome these problems. It's a tool to help your patients understand and get them to explain in their own words what you've just told them. It's not a test, but a checking system to see if you've explained things clearly enough. Research tells us that Teachback has a positive impact on how well people manage their health. It strikes me this would be an excellent tool to use with our travellers when explaining about their risks. The course teaches you a number of useful styles and tips. The e-learning is free of charge and I would recommend you take it. The link to the course is in the microlearning platform. It takes between 30 and 45 minutes to do, is interactive and engaging, using a number of teaching styles, and provides a certificate of completion. The course also explains a system called Chunk and Check. This is where the information you need to share is complex. You break it down into chunks and use Teachback at each stage to ensure understanding. I could see this working well, for example, with a traveller with perhaps complex health problems going to a yellow fever endemic area and needing vaccine. I've read if you use the system selectively and are practiced in it, it will take no longer, but of course you'll have better reassurance that your traveller has really understood. I know there are many barriers within our consultations that impact effective communication. The biggest one is time, a traveller's reluctance to pay for a vaccine, and big challenges in their own right. But do we need to improve our communication skills? And we know that language is also a great barrier. In the UK in 2018, a traveller was seen in a travel clinic and given a yellow fever vaccine when it was actually contraindicated. The explanation of what happened is in the coroner's report, available in the public domain online, but it was all due to miscommunication. It was an extremely sad and a very rare case, but illustrates the importance of clear communication and ensuring understanding. As a result of this, and one other death in a traveller who received vaccine, but with different circumstances, many procedures were tightened up in the UK. Practitioners giving yellow fever vaccine all now have to undertake training every 2 years and pass an assessment test, whereas before it was one person from the yellow fever clinic that had to attend biannual training. We have many excellent resources to use as safety checks prior to administration of yellow fever vaccine as well. There is so little evidence in the travel medicine literature about risk communication, but this paper is interesting to read on yellow fever. The authors concluded that providers need effective risk communication skills and the ability to elicit and respond to travellers' concerns to help them make informed, shared decisions. So in conclusion, we need to change travellers' behaviour when necessary. Effective risk communication and shared decision making is fundamental to that. But this and health literacy are complex subjects, and we need more education on them and even more practice. We also need a greater number of decision-making tools in travel medicine, so I personally think there is still much work to do. Thank you for listening. I hope this presentation has helped you to reflect the importance of good communication with our travellers, particularly on this complex subject of yellow fever. I'm happy to answer any questions offline in the coming days. And please remember to take a look at the microlearning site to obtain all the materials. Thank you again.
Hello, everyone. Can you hear me and see my screen? Hi, thank you so much for joining. Great information from the previous speakers. I'm Candace McAllister. I'm going to talk a little bit. We're going to go over a couple of cases and put some of the information we just learned into practical use. So I'm going to go over the first case study, which is GM, who is a 65-year-old white male that lives in the U.S. and has plans to travel to Angola for work for within the next 2 months. He's going to be there for at least a week. He will be staying in the city with no plans to visit any of the remote sites. He is up to date on all his routine immunizations, no recent hospitalizations or surgeries, has a history of hypertension and Crohn's disease, which he is taking the following medications. He's on Norvasc 10 milligrams daily. He's on Humira 40 milligrams every other week sub-Q, and he takes multivitamins every day. Now let's look at a couple of questions and we'll kind of talk about the answers as we go. So Kim, can we go ahead and have the first polling question? And you guys, please, when the poll pops up, pick the best answer, and we'll give you about a minute or so for everyone to respond. So would you offer this traveler the yellow fever vaccine, yes or no? Okay. Go ahead and make your choices. And Kim, let's go ahead and share the answers. See what we got. 20% said yes and 80% said no. Yes, I know there was a little bit of a trickier question, but as we talked about a little bit earlier, like for example, this particular traveler is going to Angola. Angola, as was mentioned earlier by Catherine, is one of the high yellow fever risk locations. Now, they no longer have a requirement to enter the country with having a yellow fever vaccine. So that's not the case for U.S. citizens anymore. So it's not a requirement for him to have the vaccine to go there, but there is a significant risk. Now, as discussed earlier, older adults do have an increased risk of severe complications from yellow fever. So we definitely want to think about that, considering he's going to a location of high risk. But he has Crohn's and he's taking Humira. which, as we know, can cause some immunosuppression. So this is a live vaccine, as discussed earlier. So we would generally say no. Live vaccines are contraindicated in patients that's taking meds like Humira because of the immunosuppression, and they would need to talk to their physician to see if they really had to go and they really want to get the vaccine. They would probably need to stop the medicine and maybe look at getting the vaccine later. So there are a lot of questions that would have to be answered before this client would actually could get the yellow fever vaccine. Okay, let's go to question number 2. Kim. So what alternative is recommended for immunocompromised travelers who cannot receive the yellow fever vaccine? So everyone take a minute and pick your best answer. Okay, Kim, let's go ahead and see what we got. 99% say yes, avoid the endemic area. That is absolutely. I know we've talked about this earlier in this session, and you're absolutely right. We would advise them to avoid travel to these endemic areas. Okay, that's all that I have for this case study. And if you have any questions, pop them in the chat, and we'll be happy to talk about them. I'll let Linda take over.
Oh, hello, everyone. Thank you so much for joining this webinar. I am just honored to be part of this, and I thank you for, I thank our previous panelists to talk about the different aspects that really highlight the yellow fever vaccine. So for my session, we are going to talk about protecting our youngest travelers. I am the nurse coordinator here at University of Michigan Health in Grand Rapids. And this is also a session where you will be participating in the polling as well, just like you did with Candace. So for the yellow fever vaccine, just a little overview, it is indicated for patients under 9 months of age, traveling to countries with the incidence of yellow fever. And this is important too when you're doing your pre-travel consultation. We can administer this to a child who has a family member who is immunosuppressed. So just someone that is in the family receiving treatment for Crohn's, the child still can have the vaccine. We need to be mindful to do all of our vaccine screening questions about hypersensitivity to eggs or chicken protein, any immunosuppression of the cells, thymic disease, malignancy, and documenting all the screening questions that we have done. And as Catherine said too, in our pre-travel consultation, we need to be asking our female patients if at the appropriate age, if they are breastfeeding. We are not to administer yellow fever vaccine to women who are breastfeeding children the ages of 9 months, younger than 9 months. Okay, so for our case study, we have a 4-member family traveling to Uganda for 2 months in August. So have your mind around that. We're going to talk about 2 different children in this family. The first is a 5-year-old with no significant health history. And if you kind of want to jot down what their immunization history, they've had 4 doses of Tdap, 3 doses of polio, the last being November of 19. They've had 1 dose of MMR and 1 dose of varicella. In some organizations, this is a combination vaccine. In my organization here at University of Michigan, it is a separate dose. They've had 1 dose of Hep A, and their last influenza was in 19, but their Hep B series is complete. Now, Uganda is in the meningitis belt. The family is going in August to the southern region. So the question that we are going to be looking at for this 5-year-old child, what immunizations would you recommend? And could we have the polling, please? Okay, so here are some choices of immunizations that are available. What would you, as the travel health provider, in discussion with this patient's family, administer to this 5-year-old child? Okay, so we can see what in another minute here of what of polling, and then we will talk about the results. Okay, so do we have the results of the polling? Okay, I like it. It is kind of across the board: COVID, DTaP, Hep A, influenza, MMR, varicella, meningococcal, and polio. And then, of course, typhoid and yellow fever. So when we look at this answer, there does seem to be people that have really indicated across the board. So let's discuss this. Okay, so for the 5-year-old, of course, almost everyone agreed they do get a yellow fever, a DTaP, a polio. They're going to finish their MMR and varicella series. They're going to get their hepatitis A number 2, their influenza, typhoid, and then COVID. Now, there's a conversation about monkeypox. So this is where in our consultation, we have this discussion about risk. So Uganda, there's only small outbreaks with very few reported cases. So we would instruct the family to avoid situations that you would increase risk, avoid increased contact with wild animals, persons with a monkeypox rash, or skin-to-skin contact. About the meningococcal vaccine, in this child, and this is always a discussion, but for this discussion, the meningococcal vaccine may not be indicated. August is in the wet season. There is more risk during the dry season, which is December through June. And they are going into the southern area. And the higher risk for meningococcal disease is in the northern region. But the Menvio is indicated for ages 2 through 55 years. Okay, so their sibling, we're going to talk about this case study. Their sibling is 9 months old. Again, no significant health history. They've had 3 doses of Tdap, 3 doses of polio, and their Hep B is complete. So the question that we have is, what immunizations would you recommend for this 9-month-old child? Again, Uganda is the meningitis belt, and the family is going in August to the southern region. So if we could have the polling piece for people to submit their answers. Okay, so thank you for thinking about this 9-month-old child and what immunizations we would recommend to protect them most effectively. Okay, I think that people will probably be done with their answers. If we could have the answer to question 2, please. And here's our response. Great. Most are getting COVID, influenza, Hep A, and we will talk about that. Some are advising meningococcal. No one is advising monkeypox, the MMR and varicella, and we will talk about that one as well, and yellow fever for most of the responders. Okay, good. So let's see once what is indicated for this child. Okay, so recommended vaccines for this child. Yellow fever, yes. MMR, now this child is 9 months old. MMR is usually given at 12 months, but because of it is such a contagious disease, it is indicated that this child does get a dose of MMR. This would not count toward their 2-dose series. So they would still get 2 more doses to complete their series in our country at 12 months and 4 years. They would get a Hep A dose. This is early, but hepatitis A can be endemic in this country, and it's recommended that children over 6 months of age receive a Hep A dose. This, as like the MMR, would not count toward their 2-dose series. For this country, it is not indicated to have the varicella vaccine. Influenza is indicated, as well as COVID. And the same as with the 5-month-old, 5-year-old. Monkeypox is not indicated, as it is a very small outbreak, and we can do education regarding minimizing risk. And then meningococcal vaccine is not indicated. For one thing, this child is 9 months, and the Menveo is only approved for ages 2 years to 55. And the family is going in August, which is wet season, to the southern area. So when we are administering the yellow fever vaccine, it is advised for the pediatric patients to wait for 15 minutes to monitor if they have any negative response. They can have mild headache, low-grade fever, tenderness at the injection site. These are all be things that we would be instructing a parent or family member. And it's important too to have family return a call to us if they do see any adverse reactions up to 30 days post-administration. And this is the yellow fever risk area of Uganda. And these are my references. And I'm just grateful for the opportunity to be presenting in this webinar for today.
All right. Thank you, Linda, and all our presenters. We have a lot of really good questions. Thank you, everyone, for populating those in the Q&A profile. So at this time, I'd like to invite all the presenters back to address these questions. I'm just going to go down, I guess, top to bottom. First question is, are there certain health conditions that increase risk of severe side effects with yellow fever vaccine and older adults outside of obvious contraindications? I'm wondering if there is a more precaution for someone who is, for example, 65 with diabetes and someone the same age with known health conditions. Are there health conditions we should look out for that would warrant more concern, or are we just looking at age alone?
You want me to take that? I'm happy to answer that one. Yeah. Is that okay, Cole?
Yeah. How about it?
Cool. We'll go for it. So obviously contraindications is immune compromise. I always, when I look at my travelers, look at their general health. So if they have lots of chronic diseases or over 60 years of age, I'm probably a little bit more reserved with the yellow fever vaccine. So in answer to the question, I would say yes, definitely. Lots of things going on with them medically, then yeah, I'm a bit more concerned about giving them the yellow fever vaccine. It's just a discussion with the traveller, and obviously just getting that informed consent. Don't know if Linda or Candice wants to add anything.
No, I agree with that, Catherine.
Okay. All right. Thank you. So next question, how long should a person be off an immunomodulating medication before getting the yellow fever vaccine?
Um, one of the studies that I read as I was doing my case study, like drugs such as Humira, that of course you have to work with your prescribing, your treating clinician for this, but they recommend being off of it for at least 2 months, and then reevaluate at that time.
All right. Linda, Catherine, anything else to add to that?
Yeah, I would agree. Follow your guidelines. So we have
Mhm.
strict guidelines here in Australia in the immunisation handbook that tells us when we can give live vaccines. But as Candice said, I would definitely work with your specialists, have a conversation, and obviously make sure everybody's on the same page before you give the vaccination.
Very good. All right. Thank you. Next question. A 65-year-old traveler who doesn't have any medical conditions and has never received a yellow fever vaccine before, will he be a candidate for vaccination if he's traveling to an endemic country? So I think the concern here is maybe age.
Yeah, age is a precaution, not a contraindication. So again, it's a discussion with your traveller, finding out how long they're going, where exactly they're going to. Obviously, they're going to an endemic area. So if he's 65 and they're aware of the risk, they've signed a consent form, then I would administer that yellow fever vaccine.
All right. Linda or Candace, anything else to add?
Would agree. In
Yeah.
that particular traveler at 65, I would recommend the yellow fever vaccine. And of course, do education regarding the first 72 hours after administration,
All right.
if there'd be any kind of symptoms.
I
Okay.
agree.
And it really depends on the country you're practicing in as well, because I obviously in the UK it is slightly different. So obviously just be aware of your rules, regulations in your own practicing country.
All right. Awesome. Thank you. Next question. Is the risk of neurotropic and viscerotropic complications the same with the booster as with the first dose?
In my
Um,
practice, I'm sorry, we do not administer a second dose if they've had a dose previous. Um, we default to that person having immunity for lifetime.
Same here, here in the US. I don't know about other countries. I know there's been some discussion about that.
So here in Australia, we would boost in certain criteria. So the syndromes have most of the cases, or almost all the cases, have happened after the first dose. So giving a booster dose for me is less of a concern. Obviously, you have to still go through the safety aspects of checking everything. But yeah, the second dose, a lot less risk. Most cases of the syndromes have been after the first dose.
All right. And I think this next question kind of also kind of addresses maybe differences in practices or country regulations, but the UK advises that children greater than 9 months to under 2 years of age be given the vaccine need revaccination at some point if they live in a risk area. It is not clear when to recommend this booster. Why is this not the same for other countries?
Yeah, it just highlights how it's difficult for us as practitioners because we all do slightly different things in different countries. So here in Australia, we would boost after 9 months if they're going to an outbreak situation. So again, you just need to be really aware of your regulations within your countries. A lot of our resources are international, like the Yellow Book, the CDC Yellow Book, which is fantastic. But we really have to be aware what is allowed and what is recommended in our own countries we're practicing in.
Okay.
Mm-hmm.
Candace or Linda, any additional comments or
I
thoughts?
completely agree. That's why we have to be always discussing. This is something that you'd be very mindful for your own country.
Right. And we always advise our clinicians that make sure they check the most up-to-date information, because even like they say with the CDC Yellow Book, when it's the print copy, that there's always updates to it that are online. So we always tell our clinicians, always check and make sure that they're and see what the changes are. Like Angola changed their requirements for US citizens, and it took a while for that information to get disseminated. So, it's why we always advise our clinicians to stay up to date as much as possible.
Thank you. Next question I have is on the yellow fever checklist. Should it also ask whether someone living with HIV has had a recent change to their medication? As I understand, this may change the assessment.
Well, I think that when we're doing those checklists and we're looking at a client's medications, especially ones that may impact their immuno suppression, or could cause that, we would make sure to ask them, of course, if they had any, recent outbreaks or any flare-ups or any changes, any hospitalizations, anything like that. We definitely want to address that.
Yeah. Any other additional thoughts, Linda or Catherine?
I would be wanting to have a discussion with their specialists. Yeah, see their recent bloods before administering, the yellow fever vaccine.
Okay. And then kind of similar along the lines of checklist, can you review again what you mentioned about yellow fever immunity / protection if given to pregnant women?
I'm happy to go ahead. So with pregnancy, we advise primarily do not travel to a yellow fever area if you're pregnant. Okay, pregnancy is a precaution for the yellow fever vaccine. However, they have to be informed, of all the details. In Australia, we would boost if you have had the yellow fever vaccine in pregnancy.
Okay.
It
Any
may
other?
be different in the States. I don't know if Linda or Candice wants to add anything to that.
Yes, as Linda mentioned, we wouldn't offer a booster that I know of. And Linda, you can chime in on that, even for pregnancy. I think you're on mute, Linda, if you're talking. I can't see your face.
Oh, today.
Okay.
I
I think
I
she's lost a bit of
yeah,
sound.
I
Yeah, so
think she lost her sound. Yeah.
yeah, so just obviously in pregnancy, follow
Yeah.
your again national guidelines about yellow fever. Obviously, it's a precaution. If I would only vaccinate a pregnant um, person if they're going to an outbreak situation. Ideally, I would encourage them not to travel to a yellow fever epidemic area.
Yeah, someone mentioned in the chat that in their practice here in the US that they do boost if it's indicated.
Okay. And so we've been kind of talking about indications, potential contraindications. And so this question is, if a client has an actual contraindication for a yellow fever vaccination, but is traveling to an endemic area that has a certification requirement, would you give an exemption certificate or just advise not to travel?
I think
For
that's
me,
a
I would.
discussion. I'm sorry, Linda, you go.
Okay, so in that situation, it's really traveler specific. Are they feeling like they need to travel? Is this something? I have quite a few travelers that are going to visiting a parent that is doing very poorly. So they feel this absolute need to travel. So in that kind of situation, I would write a waiver and then talk about insect precautions and decreasing their risk. Would you do something in addition, Catherine or
No,
Laura?
I agree. Yeah, number one, don't travel. But if they are going to travel, just informing your traveler. It's a two-way conversation. Um, you know, it's not, for me, it's not about telling them, it's a discussion and
It's a
showing them the
discussion.
facts. Yeah, and getting informed consent. So no, I would do exactly the same, Linda.
And I have a question here, I think specifically for Catherine. In Australia, can you share some examples of travelers you are boosting over 10 years? Are you boosting folks less than 60? Are you boosting any travelers to South America?
So there was a slide, so there will be in my presentation about the criteria for our boosting here in Australia. We get all our information from, like I said, the Australian Immunisation Handbook, and I've got it online here. So it's very late in Australia, so I'm going to read it. So it's really for women who are pregnant, people who have had HIV when they received their first dose, if they're going to a high risk location for an extended period of time, or there's ongoing outbreaks, and that's for anyone who is 9 months and over.
Okay. All right, thank you. And then opening it back up to the group, I think we have time for a few more questions. What specific side effect education are you talking about regarding the first 72 hours after vaccine?
So with that, there would be some neurologic symptoms, sometimes a fever, um, also some um, headache. But I really tell my patients if they are having any kind of fever, headache, change in like thought process, they need to, even some myalgias, they need to call the office.
Catherine or Candace, anything else to add?
I agree with that. We always advise our clients, our travelers, that if they have any kind of side effects after a vaccine, particularly the ones that we discuss with them, yes, to make sure to call us.
Okay, thank you.
Yeah, I would say side effects are normally 7 to 10 days after the
Yeah.
vaccination.
Mm-hmm.
So just be aware that if you're feeling headachy, achy, fever in about a week's time, that is probably due to the vaccine. Take paracetamol. But obviously, if they've got any concerns, they can always phone the clinic.
Okay. And then I think this touches on the cases that were presented in the latter part of the presentation, but considering that yellow fever is a live vaccine, and live vaccines generate a robust immune response leading to patients experiencing symptoms similar to actual disease, would you recommend scheduling a separate appointment for administration or recommend giving it with other vaccines in one appointment?
For administering yellow fever vaccine, I do administer it in conjunction with other immunizations. And I give the same kind of advice regarding precautions, symptoms to look for, but I do not administer the yellow fever vaccine by itself. For one thing, you'd have to wait 28 days if you were going to administer anything else. but we do it at our organization. We do administer yellow fever vaccine with other vaccines.
Mhm.
Yeah, so obviously live vaccines on the same day or 4 weeks apart. So yeah, I would administer a yellow fever with an MMR vaccination. But obviously, ideally, especially if there's multiple vaccines to be given, you make a little bit of a plan. And if you've got time, it's great to kind of spread them out to a certain extent. But obviously, with those live vaccines, we've got to either have on the day or 28 days between.
All right, so we have a lot more really great questions. I believe we'll be sending out, Dr. Bowie, correct me if I'm wrong, a handout kind of addressing all of those additional questions. I don't think we have time to get to it in the remaining time that we have, but is that correct?
Yes.
Okay.
Yes,
All right.
thanks everybody for all the great questions. I've been reading through them. And I just want to remind you that we're having our annual travel medicine review and update course in late February 2025. And we will have another international panel on yellow fever with case discussions. So stay tuned, watch for the announcement. And we will go through the remaining questions, and the answer will be put in a handout that you will receive after the webinar. And all the recordings also will be posted on the ISTM's learning management system. Thank you so much, Carl, for your excellent moderating.
Thank you.
Our panelists. This was a wonderful session, very interactive. And like I've said, I've been working in travel medicine for over 20 years now, and yellow fever, it's still a very complex subject. So I'm so glad that we had the opportunity to put together this webinar. Thank you so much, Tara, for pulling everybody together, a great team. And thank you so much, the nursing professional group, for your participation. And thank you, Carl, again, for being with us today. Thanks, everybody. I saw somebody writing in the chat, they are calling in from Uzbekistan. So wherever you are, thanks again for participating, and we'll catch you at another time. And happy holidays, everybody.
Thank you.
Thank you.
Take care.
Thank you.
Bye.